Still not done. But it is good. No, we did use a lab managed tool for NRC, so we've customized it so much you wouldn't even recognize it. You completely built our LIS and our Connect. What do you use?
I need a bunch of cuts. Oh my God.
You like all that?
Yeah.
Explain that.
Thank you so much. I'm sorry, Roger, with it.
I don't think there are any commercial primarily because everyone does things a little bit differently. And
So we are having
most of the things you're referring to too, they're not really limbs or equal LIS. But you don't think that we need to be down here reading? We haven't got it completed yet. We're moving out of it never gets complete. What we're seeing is, so when you put a specimen now what we're seeing is like that. You have one specimen sometimes more than one. So that just what we decide, right? Let's put the order in and don't define.
Oh, that was about
special until it's come out. But then we can divvy it up. However we want it to be. Well, let's say you have two texts, right? And let's just say one we take the word, right? That we take the word to the 99% of that let's say variance, right?
basically 27.
So if you just get one QC, as you go down to right, you're going to be failing on tests at the end and not able to share that same, right? If you had diagnostic, but had you, up front, if you just said, okay, I really have two orders, you have to use the analytical oscillation. So, and at the end too, if you have two tests that have the same identical QC characteristics, but they have different.
Wow.
Requirements for the analysis.
Yeah.
You could make a decision. I can take X amount of this. I'm going to take 20 out of this, turn it into this specimen.
Okay, we're going to start back up. Before we do, just so you know, it was discussed here prior to lunch. Once the presenters have talked, we will start right up with the panel meeting. So it'll be a continuation, so stick around. Our next speaker is Ben Roa from Myriad Genetic Laboratories.
Good afternoon. My name is Ben Roa, and I'm the laboratory director at Myriad Genetic Labs. Thank you for the opportunity to talk about our Polaris test for prostate cancer aggressiveness. So just briefly on this slide, the current state of prostate cancer lists the statistics in terms of newly diagnosed cases, the growth in the reporting of cases of prostate cancer, and the annual spend. Suffice it to say that there's quite a bit of spending. It's currently the third ranked in terms of cancer treatment, and there is widespread concern of potential overtreatment due to screening programs. And this brings us to our code 81X41, which describes Myriad's laboratory test for prostate cancer called Polaris. This is used to more precisely stratify patients by directly measuring tumor biology. And this test is for men with a biopsy-confirmed diagnosis of prostate cancer to determine aggressiveness. As you can see from the code descriptor for Polaris, 81X41 is a prostate MA analyzing RNA expression levels by RT-PCR, or reverse transcription followed by quantitative real-time PCR. The RNA expression levels being analyzed are from a set of 46 genes, 31 of which are considered content genes involved in cell cycle progression, and the other 15 are housekeeping genes. An algorithm is applied to generate a Polaris score, which has been proven in multiple published studies to be a predictor of prostate cancer outcomes. This unique patient-specific information is independent of standard clinical pathologic features such as PSA and Gleason score. And the personalized information in the test report is used by the patient and physician to make more precise treatment choices based on the patient's 10-year risk of dying from prostate cancer. When an individual is diagnosed with localized prostate cancer, he is then classified into an American Urological Association risk category. But regardless of the risk category, most men will seek intervention in the form of surgery, radiation, or a combination of both. The high rate of intervention occurs despite the high risk of treatment-related complications and the fact that the vast majority of prostate cancers do not cause death even when initial management is conservative. We believe that this high intervention rate is because risk stratification using typical prognostic factors continues to leave physicians and patients with uncertainty about the aggressiveness of prostate cancer. In turn, this results in underutilization of active surveillance and increased costs to the healthcare system. Using the Polaris test, however, enhances the existing treatment paradigm and leads to cost savings. Now, let's get to the laboratory specifics of the Polaris test. First, it's important to note that the test uses prostate biopsy tumor samples in the form of FFPE blocks or slides. Prostate tumor tissue are processed, verified, and macrodissected in our Cap and CLIA anatomic pathology laboratory under the supervision of board-certified anatomic pathologists. The macrodissected tumor material then moves to the RNA molecular lab, where RNA extraction is performed. Reverse transcription is used to convert mRNA into cDNA, followed by real-time PCR analysis of 46 genes. An algorithm is used to analyze the gene expression levels of 31 cell cycle progression genes, normalized to 15 housekeeper genes. This algorithm generates a Polaris score, which has been validated as a prognostic marker for prostate tumor aggressiveness. Finally, we issue a report with a Polaris score for that patient. The report also gives a relative comparison of that individual's Polaris score with those of other patients in the same AUA risk category. One valuable feature provided by the report is a patient's cancer-specific mortality risk within 10 years with conservative management. If the patient's mortality risk falls below the threshold of 3.2%, then a patient with localized prostate cancer can be managed with active surveillance instead of definitive treatment with surgery or radiation. So I'm just going to gloss over this slide in terms of options for crosswalking or gap fill and proceed to the next slide. So in reviewing the code at hand, we have a tissue sample with an RNA expression analysis by RT-PCR and an algorithm to yield a prognostic risk score using 46 genes. And we also have 14 mock codes that are priced. So let's look at those for a comparable test. This chart shows the full list of mock codes with final prices on the clinical lab fee schedule. We reviewed these tests and compared them to our Polaris test. And we're recommending code 81X41 be crosswalked to code 81519. We arrived at 81519 by eliminating codes with samples other than FFPE, eliminating codes with methods other than mRNA expression by RT-PCR, eliminating codes with a purpose other than risk score, and selecting codes with the closest number of genes. And the next slide applies this elimination process. So if you look at this table, given the different front-end anatomic pathology laboratory resources for running tests on tissue samples, we eliminated all the sample types other than FFPE. And so you see the codes on the far right column that are eliminated as not being comparable on that basis. Next, if we review the methodology of the remaining tests and we eliminate those other than mRNA expression by RT-PCR, then code 0008M is not comparable as it uses hybrid capture. With the final three options, we looked at the test purpose and eliminated code 81540 because the purpose is determining the most likely tumor type rather than generating a prognostic risk score. And that leaves 81519 and 81525 as similar based on sample type, methodology, and purpose. If we then look at the number of genes being analyzed, 81519 is closer to the number of genes in 81X41, and therefore we recommend that crosswalk. So in sum, for new code 81X41, we recommend a crosswalk to code 81519, since both codes describe MAW tests with the same sample type. Oops, yeah. Using the same methodology with the same purpose and the closest number of genes. Thank you.
Thank you. Do you have a question? Sorry.
Can you speak a little bit to why the test purpose is important in eliminating that other possibility?
In eliminating the code specifically for 81539, is that the question?
I think it's 540.
Yes, we believe that our test, which has at its purpose to provide a prognostic score, required resources in order to validate. So for instance, in doing so, not only did we have to show analytical validation that the test is robust, but also that it actually predicts outcomes. In terms of 10-year mortality risk, for instance, we had to study large cohorts of men whose prostate cancer was managed conservatively and then looked at longitudinal outcomes of 10 years or more. And in another example, we also looked at outcomes in terms of risk of metastasis, correlating, for instance, the Polaris score generated by the biopsy with the risk of metastasis following radiation or surgery. So those are some of the resources that went into play.
So just to clarify, you're talking about development of the test more so than the resources required to do the test.
So we think that everything, comes into play in consideration, and so we go by the methodology, the resources, and running the test, and the purpose in terms of what the test is intended to be used for. Thank you.
Our next speaker is Cheryl James from the Mayo Clinic.
Okay, great. Hi, I'm Cheryl James, presenting on behalf of Mayo Clinic. With me today are Dr. Hopman, Dr. New, and Emily Vetter, who will be able to address any questions related to the technical and scientific details of the tests we are commenting on. We are only commenting on 6 codes, which are the codes that we brought forward to the AMA. Since many of the genomic sequence analysis CPT codes have not been priced yet by CMS, recommending crosswalk to existing price codes was a challenge. The first code is 814X5, a genomic sequencing procedure for hereditary peripheral neuropathies. This new GSP code will allow a single CPT code to be utilized instead of the current 9 Tier 1 and Tier 2 CPT codes that are used. I'm not going to go into details of this test in the interest of time since the information is here. Note that this test is for diagnosis and is a next-generation sequencing test. We are recommending a crosswalk to CPT 81439, the cardiology genomic sequencing procedure, but with a multiplier of 3. Given the considerable phenotypic overlap and the broad genetic heterogeneity of inherited peripheral neuropathies, a comprehensive diagnosis genetic test is useful to establish the genetic cause in these clinical groups. Larger panels are routinely used, and the interpretation of the data requires incorporating information from the neurological exam. We feel that the ×3 accurately reflects the resources and time involved with the analysis. The next code is 004U, and this is for gram-negative resistance genes. This test is used to guide appropriate antimicrobial therapy as emerging resistance increases. This test is labor-intensive with analysis of 27 genes from the bacteria isolated in culture. With this one, we're recommending a crosswalk to CPT 87150 ×10. This test involves detection and identification of 27 genes from the patient's bacterial isolate. With the efficiencies of the microarray format, a multiplier of 10 is representative of the effort and the complexity of the testing. On this slide, you'll note that the 27 genes that are detected with that testing. 001U is another PLA code, and this test utilizes whole genome sequencing of a bacterial isolate. Again, I'm not going to go into detail on purpose and methods as it's outlined. This test, again, is a whole genome sequencing that is performed to determine relatedness of bacterial species, of bacterial isolates, sorry. On this one, we're recommending a crosswalk to 2 CPT codes, CPT 87153 ×3 plus CPT 87900. There is no CMS reimbursed CPT code for bacterial whole genome sequencing at this time, and we feel 87153 is the closest to representing the work performed. Although this tests greater than 1,500 genes, a multiplier of 3 accounts for the higher number of genes than what is involved in 87153, while taking into account the efficiencies of whole genome sequencing. CPT 87900 takes into account the bioinformatics work required to analyze the data and provide an interpretation. These two CPT codes added together fully represent the work and the resources required for this testing. The next three PLA codes I'll be addressing, 0012U, 0013U, and 0014U, are all for mate pair testing. These three assays use a novel library preparation method called mate pair, in which long pieces of genomic DNA are circularized, sheared, and sequenced by whole genome pair-end next-generation sequencing. Analysis is focused and includes 2 or more breakpoints. The difference in the codes is the specimen type. These tests are important for diagnostic, prognostic, and therapeutic purposes when the initial clinical test has failed to provide this information. Again, in the interest of time, I'm not going to go through the details of purpose and method. For this PLA code, 0012U, which requires a specimen source of blood, we are recommending a crosswalk to CPT 81316 times 2 plus CPT 81450. CPT 81316 is translocation analysis for a single breakpoint and was the best fit of an existing price CPT code that represents the translocation analysis that is being performed. The times 2 will account for at least 2 or more breakpoints being analyzed with mate pair. Mate pair will always be a minimum of 2 breakpoints, and as you'll see in upcoming slides, can average higher depending on the clinical situation being evaluated. For congenital studies, which is what this PLA code represents, on average 2 breakpoints are assessed. CPT 81450 is one of the few targeted genomic sequencing procedures that CMS has priced, and the work resources would be similar to what is involved with mate pair whole genome analysis. The 2 CPT codes added together fully represent the whole genome sequencing focused on specific breakpoints that were identified through that initial testing, which failed to provide clarity on diagnosis, prognosis, and therapy. 0013U is mate pair on an oncology specimen. The only difference between this one and the previous, again, is the sample type. Our crosswalk on this one is slightly different. We are still asking for a crosswalk to CPT 81316 times 2, but for the targeted whole genome sequencing, we're crosswalking it to CPT 81445, which is the targeted genome sequencing for oncology specimens. 0014U is mate pair for a hematologic specimen. Again, your test purpose and method are there. This one, we are recommending the crosswalk for this one to be the same as what we did for the blood specimen, 81316 times 2, plus the targeted analysis code of CPT 81450. This one, on average, hematologic specimens on average, we're looking at 4.6 breakpoints versus the 2 we saw in blood, and we were at over 6 breakpoints in oncology specimens that we're looking at. In closing, I encourage you to ask technical questions of Dr. Hopman, Dr. New, and Emily to fully understand the technical work involved with these tests. Thank you.
Since mate pair technology usually requires a confirmation by Sanger, did you not consider any crosswalks to Sanger?
I'll let Dr. Hopman.
So we do confirm everything right now at this point by Sanger sequencing, but our hope is that in the near future, once we're more comfortable with this technology, that we won't do that in most of the cases. Since that will go away someday, then we decided we wouldn't add that. The other nuance to that is sometimes we also do a different assay, such as a fish confirmation. It just depends on the situation at hand, so we did not include that at this point.
Thank you.
Hi, this is Karen again. I have a series of questions. I'd like to start with the first code, 0004U. You are crosswalking this to 87150 times 10. And my question is, how many, if I'm understanding the code descriptor correctly, you are looking at nucleic acid information. So I'm assuming you are looking at specific genes.
Correct. On the 004U, we're looking at the 27 genes that are outlined on the diagram there. So we're looking at genes for AMP-C, carbamidase, and ESBL.
Right. So the question is, 87150, which is the crosswalk, is typically how many genes are being probed in 87150?
87150, really, it's per culture or isolate, each organism. So again, that doesn't really address the number of genes that are there. It was the closest that we felt comfortable with for crosswalking, being that it was a nucleic acid amplified probe technique.
Okay, so it's not necessarily the number of genes, but just the methodology.
Each organism probed.
Okay, and then regarding that same code, how did you come up with a multiplier of 10 as opposed to 6, 8, 2, or none?
Well, initially we had looked at doing it times 27 because of looking at 27 genes. And that wasn't realistic when we compared it to the work and the resources that are required to do the work. The laboratory, and looking at the work and the resources, felt times 10 would be the feasible solution to that.
Okay, thank you. The next question I have is on code 0012U.
Okay, so that's Dr. Hopman with Medicare.
Okay, and I notice you're crosswalking it as you outlined to 81316 times 2 plus 81450. So I noticed that a translocation analysis code 81316 single breakpoint translocation lab test is what you recommended, and the rationale for the multiplier of 2 was based on mate pair testing minimally assessing 2 breakpoints.
Correct.
And I noticed that 0012U code descriptor is not specific for 2 breakpoints. So I was wondering, what is the typical number of chromosomal breakpoints that would be anticipated when you use 0012U lab test when it is recommended or requested?
So we would always look at 2 minimally.
Mm-hmm.
Sometimes what happens is the rearrangement is more complex than we could appreciate by the initial clinical test that was performed, and so we could see upwards of 3, 4, 5, 6 breakpoints. The problem is we never know until we see the data at the end of the process.
Okay. The final code that I wanted to ask you questions on is 814X5. And we noticed in reviewing the presentations from the folks who have come today that 2 other presenters have identified 81439 as having similar resources to 814X5. And I know in your presentation that you mentioned that you explained why you thought 81439 should be times 3. So can you explain that with a little more detail, why it would be times 3 when others believe it's times 1?
So basically, our rationale started with the gene content, which has been mentioned discussed this morning as well. So normally for the cardiology panel for A1439, normally including about 50 genes also. But for the comprehensive hereditary peripheral neuropathy panel, currently are about between 100 to 200 genes. So increased number of genes leads to increased causal reagent sequencing. And also one thing, another significant part is there are regions in our genome cannot be sequenced properly by next generation sequencing, therefore leading to more Sanger sequencing fill in. And additionally, for the neuropathy panel testing, we feel that very often we have to consider additional clinical evaluation results, such as nerve conduction study, EMG, sometimes MRI or CSF metabolite analysis. So we feel that there's additional effort spent on the clinical reporting and the interpretation part.
So again, how did you come up with 3?
It's a combination, it's an estimate.
Okay. All right, thank you.
Our next speaker is Robert Jarris from the American Society for Microbiology.
Thanks, Glenn and committee. Glad to be with you guys again. Bob Jarris, I'm Medical Director of Microbiology, Children's Healthcare of Atlanta, Emory University in Atlanta. Representing ASM today, over 50,000 life science members. Of those, a subcommittee of clinical microbiologists, our consortium here in the audience, and presenters from pharmacy and from commercial sources, as well as laboratories that develop their own tests. We have a subcommittee that is responsible for reviewing the new CLS requirements and old codes and new codes. And let me present the summation of those today. Microbiology, infectious disease detection, nucleic acid respiratory syncytial virus. Recommend a crosswalk to 87798. Nucleic acid not otherwise specified amplified probe technique. For Zika virus, 87X6X, we represent crosswalk to the same 87798. Infectious agent detection by nucleic acid, DNA, and RNA. Same NLA. In immunology, allergen-specific IgE quant or semi-quant recombinant purified each component, crosswalk to 86003. 86X7X Zika virus IgM, crosswalk to 86790. 0004U infectious disease DNA 27 resistance genes, crosswalk to 87150 times 27 markers, that is per reportable marker. PLA Helicobacter, antibiotic resistance by NextGen, we don't have a comment on. 0010U, infectious disease whole genome sequencing. ASM does not have a comment on that. O2X1T, under PLAs, infectious agent detection by nucleic acid, HPV. This is a category 3 code, typically not included in CLFS. We recommend crosswalk to 87623, 87624, and 87625. Code G0499, hepatitis screening in non-pregnant high-risk individuals. Took some bundling around to see what this interpretation meant. We interpreted this to be a bundled set of tests, and as such recommend crosswalk to 87340, 87341, 86706, and 86704, which represent each one of the individual components. Thank you.
Our next speaker is Michael Idowu from the College of American Pathologists.
My name is Michael Ido, a professor of pathology at VCU, Virginia Commonwealth University in Richmond, Virginia. I'm a member of the CPT ROC subcommittee of the Economic Affairs Committee, College of American Pathologists. So I'm here today to present some recommendations on behalf of the College of American Pathologists. As you know, many services within the molecular pathology and genomic sequencing procedures require similar resources and comparable technologies. And these are directly applicable to Crosswalk, as many of the discussions today have indicated. I'm not going to repeat most of what have been discussed. The complete the grid of containing the full slate of our recommendations were placed outside this morning. I will go ahead, though, and highlight some of the recommendations of the College of American Pathologists. I'll start with the new genomic sequencing procedure code 814X5, Hereditary Peripheral Neuropathy Genomic Sequence Analysis Panel. We believe this should be crosswalk to 81439 Inherited Cancer Panel. We believe these have similar methodologies, and they use similar amount of DNA, so we believe this is an appropriate crosswalk for this code. The next one I'll mention is the new code 81X04, which is gene analysis often used for myeloid malignancies. We believe that this should be crosswalked to 81317 PMS2, which they have comparable exons, and we believe they have similar methodologies and similar amount of resources, so to say. The next one I'll mention are some pharmacogenomics code, which were already discussed earlier. We agree with the recommendations of American Association of Molecular Pathologists, AMP, earlier today regarding 81X30, which is CYP3A4, that this should be cross-matched to 81374. We also agree with the ×2 multiplier that they recommended. New code 81X37, G6pd Code, and 81X35, we believe they should also be crosswalked to 81374. The new code 81X15, human platelet antigen 1 genotyping, the crosswalk we recommend is 81376, HLA typing class 2, HLA class 2 typing, low resolution 1 focus. Now we have several other new genomic molecular pathology tier 1 codes, HPA 2, 3, 4, 5, 6, 9, 15, and SLCO1B1. We also believe this could appropriately be crosswalked to 81376 as similar resources are used. Now I'll mention some oncology, at least one, the ASXL1. The previous one mentioned was full sequencing. In this case, we're talking about hotspot or targeted sequence analysis. And we believe this could appropriately be crosswalked to 81218, CEBPA full gene sequence. This may look like it's conflicting because one is targeted and one is full, but if you really look at a CEBPA, it has 1 exon, and when you look at the amount of resources you use, they are comparable. We have some hemoglobin genes, tier 1 codes, H1X58, H1X59, H1X69, and revised code 1257. These are hemoglobin A1/A2 gene analysis family. We believe these could appropriately, as mentioned earlier on today, be crosswalked to H1235 EGFR code. Another oncology code is H13XX, which is an RUNX1 targeted gene. Again, this is used for myeloid malignancy. We believe this could appropriately be crosswalked to H1235, again, as similar resources are used. Now, the next one I'll highlight is H1X25, which is a full gene sequence analysis to detect pathogenic mutation in F9, factor 9, with factor 9 deficiency. Crosswalk recommended is H1321 P10 full gene analysis panel because they similar work again. Now, there's another one that use similar methodology, MLPA, multiplex, ligation-dependent probe and amplification. That is CPT code 81294, excuse me, CPT code 81X69, which is HPA, hemoglobin A1 and A2. And then this we think should be crosswalked to CPT code 81294, which is MLA duplication deletion, because that is exactly what you're looking for in the code previously mentioned. And similarly, code 813X3 also looks for duplication deletion, and we also think it could appropriately be cross-matched to 81294. We will also mention some codes here, IDH1 and IDH2. They look for common mutations. We think this could, as mentioned earlier on, be appropriately cross-matched, that is IDH1 to KRAS 81275, and then IDH2 could be cross-matched, excuse me, not cross-matched, crosswalked to 81311 and NRAS gene. Earlier today was mentioned the new immunology code, the IgE. It is, I believe, at this time that this could be appropriately crosswalked to 86003. We had the previous comments, but at this time, the recommendation of the College of American Pathologists is that this is appropriately cross-matched to 86003. And then lastly, 81327, the SEPT9 that was mentioned earlier on, we agree with the previous recommendation of crosswalking this to 81288. Again, the full list of our recommendations are listed outside. They're printed and they're outside in the grid. We wish to indicate that as private payers often use Medicare clinical laboratory fee schedule as a national limitation amount, it will be, we believe it's important for CMS to use this transparent medium, the nature they are using here, the annual process, subsequent comment period, to make preliminary payment determination using these crosswalk methodologies that have been highlighted, because this will make this easier for patients to understand and will make it more accessible. So at this time, I will entertain some comments or questions, if any. Yes, ma'am.
Hi, this is Karen. Thank you for presenting a summary of these codes. I have a series of questions for you. And the first code is 3813X2. And we noticed that there is a split between some of the presenters. Some have recommended 81215 based on these genes being recessive versus 81275. Those who have recommended 81275 feel that this has this code represents similar resources. So my question for you is, between 81215 and 81275, which code represents the most comparable use of resources and methodology for this new code 813X2?
813X2. Let me quickly find that. I believe let's see. Okay, so 813X2, because this is a non-familiar variant, we believe is appropriately crosswalk to a non-familiar variant, which is a BRCA. So at this time, our recommendation is it could be appropriately crosswalk to H1215.
Okay, thank you. Next question is, well, we've kind of asked AMP on that one, so I'll skip that one. The next question is regarding code 81X30. It's a pharmacogenomics code. So, again, there's been a split. Some of the societies are recommending that this code be crosswalked to 81374 times 2. And others are saying that it should be crosswalked to 81227. So for code 81X30, what is the most comparable code, 81374 times 2 or 81227?
Well, as the code 81X30, it's this CYP3A4, we believe at this time is probably best crosswalk to 81374, HLA class 1 typing, low resolution with the times 2 multiplier, as mentioned by AMP earlier. We agree with that recommendation.
Okay, thank you. Regarding 81X35.
Okay.
Again, there's a split between the societies. And they are giving us in their presentation similar rationale, saying that crosswalk 81374 times 2 is most comparable in methodology and resources to 81X35. Yet there are other societies that are saying the same thing, but using 81227. Again, what is your rationale for the codes you are recommending for the code you are recommending as crosswalk for 81X35?
Well, so 81X35, the TPMT code, this time we are recommending that it's best crosswalk to 81374, HLA class 1 typing with the 2 multiplier as highlighted earlier. That is recommendation at this time.
And it is based on the fact that you believe the 81374 times 2 captures the resources required for the code in question?
Yes, the crosswalk that we are recommending, they are based on the similar amount of resources and methodologies used. So we believe that is the case.
Okay, thank you. And I believe that's it. Thank you.
Our next speaker is Paul Sheaves from the American Clinical Laboratory Association.
All right, well, hello again. Welcome back to Baltimore this year. Again, I'm Paul Shives with the American Clinical Laboratory Association. Just to remind you, ACLA is a national trade association. We're comprised of large reference labs, regional labs, esoteric labs, nursing home labs. We have a pretty broad membership. When we were looking at the sheer volume of codes this year, we realized that we weren't going to be able to provide comment on every code within 10 minutes. So what I want to do is kind of take you through a highlight of some of the comments that we made. There is a grid. It wasn't out there at the first of the meeting, but I noticed almost all of them are gone by now. So I think folks have copies of everything where we included, even when we didn't provide comment, something on that grid, and you can look and see what we think about it. So just a few highlights, just kind of how we approached it. There were a number of codes, particularly in the molecular gene testing space, that our members may not perform a substantial volume of, and where that happened, we really tried to defer to other stakeholders, and we made note of that in our comments. For those genetic tests that ACLA is providing comments, we've offered a crosswalk in every case to an existing test or with similar materials, methods, purposes, and other pertinent technical information, even trying to get into, in our discussions, related to the number of exons, the amount of genomic sequence analyzed, et cetera. We didn't, for at least the ones we provided comment on this year, feel that gap fill was appropriate for any of those codes. Just some kind of high-level thoughts here, because we have a little bit of newness this year in relation to the MAAAs. And that is, in the past, we really have had to gap fill these things because there hasn't been anything on the fee schedule. Now there are, up to 14 codes on the fee schedule that we can look at and see what is similar, and look at crosswalking strategies. Those have kind of failed in the past because they didn't have algorithm-based tests when we tried to do crosswalks and didn't really account for the entire test. And gap fill may still be an option if there's one that's on there that we're trying to look for, and there's not a code that's similar enough. It's not that we don't think gap fill could be used, but for the ones that we provided comment on this year, we felt that there was an appropriate crosswalk for those codes. I guess I'd first just mention our crosswalk on the RSV amplified probe technique code. We also provided a crosswalk at 87801 and with a 2017 NLA of 9628. We're looking at the Zika virus code. There's the amplified probe technique, and then there's the IgM. In both of those cases, we've actually received some kind of new information from our members, and are kind of reevaluating what we're recommending for those. We still haven't landed. So I would kind of look at those as maybe preliminary recommendations, but we may be modifying our recommendations on both those codes during the follow-up written comment period. Let's keep going. So for the MAAAs, for all of them, we had recommended the crosswalk to 81519. Again, that's really based on different components. I know Dr. Hambrick had asked the question about a number of genes. We think that's important. We think that's one factor to look at when you're looking at also sample type, methodology, type of result, and purpose of the test. I'll cover, I guess, the crosswalk that we recommended for the allergen testing. We had a number of in-depth discussions about this and looking at the proposals, but we came up with crosswalking to 86157 at 1103, and we really felt like that best represented the cost and resources required for each component of the allergen testing. All right, and then we'll jump way forward, and that's because there are so many MOPATH codes this year that I'm not going to try to just read you numbers and dollar amounts. But all of our recommendations where we didn't defer to someone like the Association of Molecular Pathology are within our grid comments. So I think we'll jump to 14. I wanted to make note on the Hep B code, G0499. We actually provided kind of a bifurcated recommendation, and really the reason we did that is it was unclear to us in looking through at the actual descriptor and then also looking through AMA materials really how to approach that code. It almost reads like it's talking about some sort of a reflex test, and so is it a reflex test that then always includes what we're talking about afterwards? Is it just the initial antigen testing? Our coding committee couldn't really come up with what we felt was the right answer there. So we provided two different crosswalks kind of based on how you view that code, and that's kind of what we put out for your consideration. Slide 15. First, how we approach the PLA codes. I think I'll jump first to the reconsideration request, because the longer you stare at this slide, the more ridiculous I look. We did not, in fact, propose to crosswalk to a code priced on the clinical lab fee schedule at $81,288. We just didn't think it passed the sniff test more than anything else. But anyway, yeah, so Excel obviously converted that to a dollar amount. When we looked at the SEP9 code, we did do the crosswalk to 81288, and that's only $160.76. So now I'll go back up, now that we've gotten off that number, and talk about generally how we as an association approach the PLA codes. I mean, those are proprietary codes, right? And when we look at coding and pricing recommendations within our committee, we really kind of poll membership, look at, what are the resources, materials, costs, et cetera, to do this. And that's how we come up with our recommendations. For proprietary code, if they're not in our membership, or we hadn't received the information in time to make a recommendation, we didn't feel it was appropriate for us to kind of weigh in on those. But I don't think that means that we're going to be completely disinterested, because we do want to make sure that there's some rational basis for those. They are going on the clinical lab fee schedule. They could serve as future crosswalks, et cetera. So we're kind of taking a reactionary approach based on what we saw from the different presenters today on their PLA codes. We do have, Aegis is in our membership, and we did have some good discussions with them on their rationale. They haven't presented yet, but we are supportive of that rationale when you hear it. So I wanted to note that. Let's see. And they took out the definitive drug codes. There's also another issue that we wanted to raise, and this was kind of fair game on the agenda today, because we'd also like to provide some initial comment on CMS's recent proposal regarding how to price the new 2017 codes in 2018 if the test was initiated and the NLA set by a crosswalk. And before describing the proposal, we just note that CMS revised the list of codes for consideration for this meeting with respect to this issue only about a week ago, and after the comment period for oral presentation had closed, so I don't have any slides to show you. But this also kind of left stakeholders with inadequate notice and only about 2 weeks to come up with written comments. So we are working diligently to try to get through our membership and look at this proposal that CMS has put out. But I'll briefly describe it. It may be that folks maybe haven't even seen it yet. As we understand, CMS didn't receive PAMA data for the new codes that were effective January 1st, 2017, and this should be obvious because the data collection period, of course, was in 2016. I think we had understood that, okay, well, those will just kind of go into the next round, and kind of these initial crosswalks and gap fill rates will just remain until there's another round of reporting. Further, I guess we understand from the proposal is that they're proposing to use the PAMA data from the the PAMA data from the codes that served as the crosswalks in last year's meeting for the 2017 codes, use that PAMA data to set the price for 2018. Again, we just got this about a week ago, so we're kind of looking how that squares up with the PAMA statute and regulations, and don't really have an answer there yet. But even if it is permissible under those, our initial reaction is that this approach may be inappropriate for a few reasons that we're trying to flesh out and provide the agency some written comment during the comment period. So anyway, we just wanted to kind of put that on people's radar if you hadn't seen it, and also just to note to CMS that we're working hard to try to get you some useful feedback on that proposal.
I want to make sure I understood you right. You said you all, ACLA, didn't comment on PLA codes because you didn't think that all the PLA codes were really PLA codes, or
no,
proprietary?
So, yeah, I'm sure I was confusing. So they're all proprietary, right? And so if they're not, if whoever got that code, whatever lab went out and got that code, isn't in ACLA's membership, we don't have any optics into their resources, methodology, materials, costs at all, right? So, we're trying to look at it as, see what's proposed and just see if it sounds reasonable. We'll probably just stay out of it completely, as long as something's not out of whack.
But what do you do when you see, like, someone goes out and gets a PLA code for what obviously is just another genome GSP code?
Right. Yeah,
and we all know that
Yep.
technology, right?
Right.
So what do you see in the future? Do you see we crosswalk that PLA code, and then everyone in the future that does the same technology gets another PLA code and crosswalk to that PLA code?
It might be. I mean, that's one of the reasons I'm saying we are paying close attention to it. But you know, most of the PLA codes that were proposed this round, we didn't feel like we're close enough to something that, you know, we needed to say, hey, you know, we need to have some skin in that argument because we need to. Yep.
Our next speakers are Matthew Schultz and Lee Hilborn from the American Society for Clinical Pathology.
You'll get one of us because we're going to be very quick. The good news is that at this point, most everything has already been said. So saying it again would bore you to death, and I know you have other business. Just a couple things. I did want to comment. I am Lee Hilborn. I am representing American Society for Clinical Pathology, but by way of disclosure, actually, I am also an employee of Quest Diagnostics and UCLA. One of the codes to comment on is 86X6X, which is the molecular Zika code. And the reason I'm commenting on those is we've heard a lot of controversy about some of the pricing related to that. And I don't really intend to repeat all that's been said. We recommend a crosswalk to 87502, and really the main reason is for the resources and so on that have been already described. And the same thing with the Zika IgM antibody 86X7X, the same thing in terms of the resources associated with the EUA and the work that needs to be done specifically with it. We're recommending a crosswalk to 86357. And then the last one, the same thing, we've had discussions already about 8600X, the allergen specific, the component testing, and for the reasons that we've already discussed, that the increased costs associated with preparing the antigens lead to an increased cost to the to laboratories for the kit, although the testing aspects of it are very much the same. So with that, I think that ASCP will provide a list to CMS of all of our recommendations for all of the codes. But you've already heard from AMP, you've heard from ACLA, CAP, and many other stakeholders, ASM. So I don't want to belabor those. I do want to acknowledge also, though, as a co-chair for the PLA Technical Advisory Group, we thank you for considering the PLA codes because, frankly, if they're going to be successful and have traction, that we need to discuss them and recognize them. And it was very encouraging to see that, in fact, there was explicit discussion of 13 of the 17 codes that have gone through so far. And there's another group coming in a couple days if we're successful. And thank also panel member Vicki Pratt for being so diligent in terms of working on that with us.
Can I ask you the same question since you're a recognized expert in PLA codes?
So
if you see a PLA that's obviously just another version of a newer GSP code that was never assigned, how do you think we should manage that?
Well, I think I think we need to look at the test. I think that that's what the presenters have sort of said, is that if you look at this test, this PLA code, that it looks like either this other GSP or something like the GSP, and that's why we recommend this set of codes. So I think that that general recommendation to look at it relative to others is wise. Then in the future, once those are priced, in fact, that you may turn to those in the future for pricing subsequent ones as well. And I think we'll have more data from the public, the commercial pricing as well, that will come in with time that will be informative for this as well. So I think that we'll have much more interesting, you'll have a much more interesting discussion, I think, come next year.
Our next speakers are Joel Galanter and Josh Schrecker from Aegis Sciences Corporation.
Thank you, Glenn. I'm Joel Galanter with Aegis Sciences Corporation. I'm soon going to turn it over to Dr. Josh Schrecker to let him detail the test in more detail, but this is the Aegis drug-drug interaction test, which is a drug interaction test of 120 more drugs and substances. It's utilizing state-of-the-art definitive tandem mass spectrometry instrumentation to report whether these drugs and substances are present. And then for the drugs that are present, it provides an assessment of interactions and provides a description and severity of the potential interactions. But as I said, I'm going to turn it over to Dr. Schrecker to give more descriptions of the test and its purpose, and then I'll be back to discuss our crosswalk proposal, which, as Paul Shives had mentioned earlier, we work closely with ACLA on it and have their support for our crosswalk proposal of GO483, and I'll explain that when I come back.
As Joel said, my name is Dr. Josh Schrecker, and again, I'll be providing some information specific to the test itself. Just to give you a little bit of background on why we ventured into this type of testing, we have a great understanding that despite the fact that drug-drug interactions are preventable, and we've had a great deal of innovation in electronic medical records at both the point of prescribing and dispensing over the years, we still see publications on an annual basis detailing a great deal of patients that are affected at any given time based on what they're prescribed, affected by drug-drug interactions. And we do have an understanding that drug-drug interactions do drive adverse drug events, which can potentially lead to hospitalization and patient morbidity and mortality. So you couple that with the fact we also see a great deal of statistics on the amount of overrides of interruptive drug-drug interaction alerts at both the point of prescribing and dispensing. And this is further complicated by the fact that we really also have no objective information about what patients are often taking that can cause interactions. So we identified a problem, again, based on in our patient population, despite all of that innovation we have in place. So just to give you a little bit of information about our test itself, this is a targeted approach to identifying substances that are known causes of kinetic and dynamic drug-drug interactions with medications that are commonly prescribed in pain management and psychiatric settings. So, some of the substances are prescription medications, some are over-the-counter medications, some are supplements, and we even have a few markers that improve objective detection of recent ingestion of grapefruit, which is a known CYP3A4 inhibitor. So we will report kinetic and dynamic interactions based on the subjective information that we have. Patients submit urine samples that undergo mass spectrometry testing. It's a solid phase extraction that's coupled with ultra-high performance liquid chromatography and tandem mass spectrometry to identify those recently ingested substances that, again, are known causes of drug-drug interactions with those medications commonly prescribed within this patient population. And that's going to be coupled with assessing each positive substance in the test with, for the potential of an interaction with one another. So anytime two or more substances are identified, they are assessed for interactions based on an internal proprietary drug information database that we have in-house. So I do want to briefly provide some additional information about some of the drug classes that we cover in this testing to give an idea of the complexity of this test. These are substances that cover a great deal of indications. There are, obviously, as you can see there, about 35 classes that fall outside of current CPT coding, which I will turn over to Joel to discuss in more detail.
Thank you, Josh. So as mentioned, there are numerous drugs and substances in this test that are all reported against one another when they're present to display and assess and give a severity indication of the interactions that are caused by the current use of these substances. many of which we have found out in putting the test together over the years are not contemplated by the current CPT code book. As indicated on this slide, there are 10 or so that either fall within the drugs of abuse definitive codes or there's a few chemistry code drugs that are listed that do fall within, but the vast majority of the 120 substances fall outside of this, the current CPT code book. And the crosswalk that we're recommending for this test is most similar, we believe, to G0483, which is the definitive drug testing of 22 plus drug classes for reimbursement of $253.87. And the rationale for that, I think, is fairly obvious, that this is a very large test of 120 plus substances. You can break it out into about 47 different distinct drug classes. However, the vast majority of those are not currently contemplated in the code book. And then in addition to the drug test that's part of this, there is a very large portion of the test, which is the drug-drug interaction database that we have and report out that information with the test. And I'll be happy to entertain any questions, and I'm sure Dr. Schreiber will as well. Thank you.
Okay, before we continue, I wanted to find out if we had any updates on data from Brian Yang and Kevin Trainer. They had mentioned they were looking up some information. Brian?
Thank you. Yeah, there was a question during my presentation on, I guess, two different questions that I'd like to add some clarity on. One was what my thoughts were on crosswalking to CPT code 86157 as opposed to crosswalking to some sort of multiplier of 86003. So now kind of being a little bit more familiar with, so 86157 is for cold agglutinin titer. You know, I think that I just have to respectfully disagree with crosswalking to that specific code, largely because we have a test with a very similar methodology, 86003. It's run on the same technology platform. The methodology is the same. The difference is in the kit price. So the methodology for performing cold agglutinin titers is not going to be anywhere near as similar as 86003 in terms of methodology. So I guess I would disagree, with crosswalking to that CPT code in particular. And then as far as I guess additional thoughts on crosswalking to 1x of 86003, I think perhaps those recommendations did not factor in the difference in kit price. So, as I mentioned, the methodology for running CRD, component resolved diagnostic testing, and 86003 whole allergen testing are very similar, run on the same instruments. It is really a difference in kit pricing. And as I mentioned in my presentation, really three big differences in why the kit prices are different. One is that preclinical work, validation for components, can take up to 2 years per component, or an average of 2 years, I say, per component. There is none of that occurs with whole allergen extract testing. Second is in production. For component tests, takes about 10 months to produce component reagents. With whole allergen extract tests, takes 1 month. And then finally, many of the most commonly used component tests have IP licensing fees associated with them, and many of them are upwards of four times the production costs. So there is a very distinct difference in the kit costs of the component tests and our whole allergen extract tests. So that's why we felt a multiplier 5x of 86003 is the most appropriate for crosswalking. Any questions?
Hi, everyone, and thank you for the opportunity to come up and clarify some of the comments that were made earlier today. So the first was in regards to our request to crosswalk to 81403, which is the Tier 2 code that did not have an NLA. Some of that confusion came from an interpretation of the crosswalk guideline. stating that they would pay at the lesser of the billed amount, the local fee, or the NLA. And we weren't sure on the interpretation of that as in the absence of an NLA, does that default to 0, as you mentioned, or does that default to one of the lesser of the other two? So I was hoping to start by perhaps getting clarification on that point.
I think we need a clarification from CMS. So if the NLA, if there is no NLA for 81403.
Right. As I just have a quick question for Sarah. Is that on the? I just want to confirm whether that's on the gap fill list. Okay, so, once we determine that, I think we can better answer that question. In general, as we discussed, part of what you're describing is what is done at the billing level, which is a different set of folks who oversee that. For the purposes of this meeting, we would need to assign some way to obtain a price for your test. And that would be done in a very binary fashion, as you indicated, as either crosswalk or gap fill. I understand that there are LCDs out there. And so I guess in a long, convoluted way, if we were to use those LCDs, I suspect it would fall under gap fill.
Okay, that's ultimately, I think, where we wanted to reach, is to use those LCDs to establish the rate on the PLA code. So in light of that and some of the confusion on the crosswalk, we can revise our recommendation to say that we'd like to pursue the gap fill, and that should be underway with 81403 and see that through.
All right, and I just want to check, are Valerie or Sarah Shirey Loso here?
Over here.
Oh, great. I don't know if you want to add anything to what I just explained.
No, that's fine. What you stated was fine.
Okay, so I think we have one more question.
Hi, Brian Lloyd. We talked a little bit about the amount assigned to a proposed CPT code. You taught us about contractors who have given gap-filled amounts in accordance with their LCDs. Can you describe the range or any of the amounts that are associated across those different carriers, or how they arrived at those prices?
I haven't seen a range. I've seen averages just in getting that number sent back to us. I haven't seen it from each respective MAC, but I've gotten data handed to me averaging that. They did not publish public rates, so we have asked customers of ours, anecdotally, how much have they been seeing. So it's coming through that source.
But you have no numbers for us today?
The anecdotal average that we've seen is around $720. And
$720.
That is the total cost to them, inclusive of the price of our test, along with all the consumables required to actually run that in the lab.
And you have no detail on how they arrived at that?
We did. So that number was provided to all of the MACs when they were developing their local coverage determination. So we had data that we provided to them about the price of our test, the time it takes to run, the consumables that are used in that test, along with some customer data that was supported from people using the test.
So their gap filling process was an evaluation of your submitted cost data. Is that accurate?
Correct.
And most of those carriers reacted to that and either accepted it or modified it?
They accepted or took the rate that was published by a different MAC and published a very similar coverage determination themselves. So I think some of them might have been referenced from another MAC, but that was ultimately from information we provided.
So some MACs use the MAC's prices established by other MACs.
Correct.
Thank you.
Thank you.
Okay, I had mentioned in my opening comments about we have recently reposted about rarely billed codes to Medicare, and for that, we're going to have Val Miller come up. Valerie is the director of the Division of Ambulatory Services, and she's going to say a few words about that.
Okay, so this isn't really about the 13 that were recently posted. Right, okay. So as we've been going through our analysis of the private payer rate data for the new rates that are to be implemented January 1st, 2018, we've also been looking at codes on the clinical laboratory fee schedule and their utilization in the Medicare data. And we've identified approximately 60 codes where there is no utilization in the Medicare data or very, very low utilization for Medicare. So for those codes, then we checked the private payer rate data, and we also found in the private payer rate data, we have received very little data for those codes. In most cases, we've received no data for those codes. There are situations where we may have received private payer rates but no volume, or volume and no private payer rate data. In all of the cases, there's either one lab or two labs that are reporting data for these codes. We're still in the process of analyzing this data. We expect by the end of this week to post those codes because we don't have enough data to develop a private payer rate. We don't even have enough data from one lab, complete data from one lab to develop a private payer rate. And by complete data, I mean it has to be a private payer rate and volume associated with it in order for us to be able to calculate private payer, a weighted median private payer rate. So we're planning to post these codes on our website, and we're looking for public comment on, one, if these tests should even be included on the clinical laboratory fee schedule. We want to reduce reporting burden as much as possible. So if these are tests that really aren't utilized in the Medicare population or have extremely low utilization, we'd like your input on whether or not we should include the test. And then if we should include the test, then what method of payment should we use for those tests? Should it be crosswalking or gap filling? So again, those codes will be posted on our website later this week. The written comment period following this public meeting ends on August 11th, and so we'd like your written comments for those codes by that date. Any questions? Glenn?
Thank you, Val. Okay, our final speaker is addressing topics that are out of scope with today's meeting. However, we will allow their presentation today, and that is the American Medical Association, Sylvia Trujillo, and Shannon Curtis.
Thank you on behalf of the physician and medical student members of the AMA, and we appreciate the indulgence of the agency and of the panel to consider our comments even though they're outside of scope. At this time, we would like to provide comments concerning the 2018 Medicare Clinical Lab Fee Schedule. I offer recommendations to address the difficulties created by retrospective data collection for most of the tests on the clinical lab fee schedule that are not being discussed today, but for which prices will be calculated and posted on January 1, 2018. Specifically, the retrospective data collection requirement under PAMA implementation has hampered accurate data collection on private payer payments. We are also concerned, in addition to questions about the integrity of the data collected, that the mechanism and methodology employed by the agency to calculate the final number is not transparent, meaning it'll be very difficult for stakeholders outside of the agency to ascertain whether or not the data submitted, even assuming it was all accurate, was calculated and processed properly to calculate the final number. And though we appreciate that today is about specific codes, time is of the essence. We have less than 6 months for pricing of the rest of the CLFS. So just to step back a moment, and let me see if I can get this to move. Step back a moment. The rule was finalized in 2016, and it was believed at that time, the agency believed they would be in a position to post the rates September 2017. And even under this schedule, it will be exceedingly difficult for all the stakeholders to, within 30 days, evaluate those posted numbers and be prepared on January 1 to make the appropriate adjustments to their clinical practice. In particular, I speak today of the physician office-based labs, but this is true for the small independent labs and even the large reference labs, that many of the POLs we anticipate based on preliminary analysis could very well cease to stop offering these services, as well as the small independent labs that they rely upon, and that will make it very difficult for them to make arrangements for their patients. Similar to CMS and all the stakeholders here, our goal is to ensure beneficiary access to clinical testing. We, as the AMA, also have a very strong interest in the congressional intent of market rates being accurately reflected, because the clinical lab network currently, physician office-based labs, small independent labs, and the reference labs really provide a front line to detect the outbreak of infectious disease. It's also very essential from our perspective to move care closer to the patient, to support care coordination and communication. And certainly not last or least, we are really at the cusp of implementing major payment and delivery reform under MACRA, and this will coincide exactly when the PAMA pricing will go into effect and impact many physician practices and the whole healthcare ecosystem. So the AMA has a number of recommendations that we urge you as the advisory committee as well as CMS to consider. First, we understand that there is an interest, and we would like to echo it, that the preliminary data that CMS has obtained, we are urging the agency to release in August with regard to the number of labs that have reported the types of lab and their geographic distribution. We believe that will give us a better sense, at least at a very high level, with regard to the integrity of the data and the extent to which it actually reflects market rates. We also urge the agency to meet its pre-identified publication date of early September. As I noted, even under this schedule, it will be very difficult for us to make adjustments in the physician community if, as we anticipate, there are significant cuts. We also are strongly urging CMS to issue an interim final rule for two purposes: not to supplant the current PAMA pricing exercise, but rather to validate the accuracy of the data collected. This is very consistent with its authority to ensure the program integrity of the data. And to the extent that there is a large discrepancy between the data collected under the PAMA regulation and in a targeted survey, make appropriate adjustments that account for what could be program integrity problems with the data. However, we'd have a caveat. We believe that there are certain laboratories, rather certain tests, sole source tests, where the integrity of the data is very high. Most of those laboratories were very involved with PAMA and had the infrastructure to retrospectively collect data. And they also are well positioned to know whether or not the final number generated by CMS represents the weighted median of the data they submitted. I won't elaborate in great detail with regard to why we believe the data collection period was hampered. Suffice it to say that during the proposed rulemaking period, the AMA very clearly communicated that based on decades of experience implementing very new programs, that there's an established formula for rolling out a very onerous, administratively intensive process, and that you typically need to provide the physician community at least 6 months notice of the program, 6 months for them to prepare before they actually have to begin implementing the responsibilities under the program. Under PAMA, the opposite happened. Physician practices, small independent labs, to a lesser extent the larger labs, they were probably more well aware of what was happening, did not know about this reporting obligation, and more importantly, were unaware until nearly the whole 6 months of the data collection period had run what were the actual data points they had to be capturing and reporting to the agency. As a result, we believe that our members did not receive adequate notice of what was expected of them, and therefore it is not unsurprising that they had difficulty generating or even knowing that they had to generate this data. And this is further validated by the fact that the largest labs themselves were reporting difficulties who had the infrastructure for the data collection. We would just like to underscore that the most vulnerable patients are going to bear the burden of the confusion and the difficulty in accessing near patient care or care testing that occurs near patient care rather, and small community lab testing as well. We have many examples of, for example, oncology patients that require testing before they receive their chemo treatment, and an analysis was done of some of the typical tests that would be performed in such a scenario. This is often either offered near patient in the physician office lab or based on community lab testing where there's an established relationship with the oncology practice. We have one example from New Mexico of a clinician who provided us this information. I just underscore that our concerns about the cuts are not simply that there will be cuts, but that the accuracy of the data has been undermined, so these cuts will be even steeper across the board, and therefore will cause even greater disruption and lack of access for Medicare beneficiaries. I won't belabor the public health issues, but we've talked previously in other arenas about the important role of the diversity of clinical laboratories in this country, and that even a physician office-based lab has a role to play in ruling out what otherwise could be infectious disease conditions a patient may have that are not warranted to go to a reference lab, but which a reference lab would not need to rule in or out whether or not there's an outbreak. And so this plays a very important role in our public health network, and we're concerned that a very large percentage of that network literally will go away at the beginning of 2018. And then I mentioned the MACRA implementation issues. We are already struggling as a profession and as a healthcare community to implement some pretty sweeping and dramatic changes in Medicare payment and delivery, all of which go into effect at the beginning of the year, at the same time that we are going to be implementing these PAMA changes. So we respectfully request both this panel to consider the issues that we've raised and the impact not only of this on the large laboratories or community labs, but the physician office labs and the agency, and we thank you for your time.
Okay, so this concludes the public meeting for new and reconsidered codes. We'll now begin or at least start the advisory panel meeting. But before I turn the microphone over to Karen Nakano, chairperson of the panel, we're going to take a break. Take a 10-minute break, and we'll begin again at 2:40. See you then.
Gilmore.
Don't let me know.
size for next year. They sent me. So I just wanted to let you know that I will have
I'm now, telling Sarah, I'm now Aaron Boyd.
You're what?
Aaron Boyd.
Oh, yeah. You've been demoted.
Yeah, I realize that. Is it? Okay, so could I ask everybody take their seats so we could get started? Okay, great. Let's see. I think we have all the panel members seated.
That would be a little difficult.
So what I'd like to do is, first of all, welcome everybody back from that little break. And as most of you know, my name is Karen Nakano, and I'm taking over Steve Furrow's position since he has retired from the agency. So what I'd like to do very quickly is start to my left with Dr. Kuchar-Lapati, just to introduce yourself very briefly, 1 or 2 sentences to get started so that the folks on the phone know who's speaking.
Cannot hear you over here.
Is this better?
That's better.
Okay, sorry about that. So I'm going to start to my left and with Dr. Kuchar-Lapati. And also I was told whoever speaks to really get quite close to the microphone because they're having problems hearing us online.
I'm Raju Kuchar-Lapati from the Department of Genetics and Medicine from Harvard Medical School, and I'm a geneticist.
I'm Rebecca Sutphin. I'm a board-certified molecular and clinical geneticist. I'm a professor of genetics at USF Morsani College of Medicine and the chief medical officer at Informed DNA.
I'm Judy Davis. I'm Director of Quality Management at Vanderbilt University Medical Center in Nashville, Tennessee.
I'm Brian Loy. I'm a hematopathologist, and I work for Humana. It's a commercial contractor payer.
Carl Morrison, Professor of Pathology, Roswell Park Cancer Institute, President and CSO of OmniSeq, Inc., molecular diagnostics spinoff of Roswell Park. Thank you.
Stan Hamilton, Head of Pathology and Laboratory Medicine, MD Anderson Cancer Center in Houston.
Michelle Skumaker, Vice President of Government Affairs with Cepheid, which is now part of Danaher Corporation.
Vicki Pratt, Indiana University, Department of Medical and Molecular Genetics, Director of the Medical and Molecular Genetics Laboratory and Pharmacogenomics Laboratories.
Vicki Basowski, I'm a diplomate of the American Board of Medical Microbiology and a professor of pathology and laboratory medicine at the University of Tennessee Health Science Center in Memphis.
Okay, so what I'd like to do is start with the first code, and we're going to follow the agenda that was sent out where it lists the codes by groups that are consistent with the CPT AMA manual. So the first code is 81X04. And this is the ASXL1 additional sex COMBS like 1 transcriptional regulator. And I want to open it up to the panel if they have any questions. Go ahead, Dr.
I just wanted to let the panel
Schoonmaker.
members know that I sent you an Excel sheet that has a summary of all of the recommendations that all of the speakers have made, and it's sorted by code, so it can help maybe streamline the process a little bit faster.
All right. Do we have any questions from the panel for the presenters? Any questions amongst the panel members for themselves? So is the panel ready to cast their ballot on this? Okay, so Glenn will, as in the past, pick up the ballots, and then the staff members here, Sarah and Rashida, will be calculating it. And then Rashida, when she is ready to announce the outcome, she'll put her name card up, and then she'll take the mic and announce it. So while those cards, those ballots are being collected, I want everyone to take a look at the next code, and that is 81X05. This is ASXL1. It's a gene analysis, targeted sequence analysis, for example, exon 12. So again, does the panel have any questions for the presenters? Any questions amongst themselves? Is the panel ready to cast their ballot? Okay, great. Oh, hold on a second. We have a question from Dr. Sutphin.
Michelle, I'm just having a question about your spreadsheet. So when I look at this one, it looks like there were 2 different recommendations, but the pricing is essentially the same. Is that correct? Am I reading it correctly?
I'm double checking that one.
So just so the public knows what's going on, Dr. Schoonmaker was kind enough to summarize all of the responses from the presenters, and they're trying to go over that worksheet real quick.
The 81374 times 2 would have been a 199. Sorry about that.
Have you two settled that and figured out what you need?
Not really. I just want to make sure. Were there 2 different recommendations? And are those captured accurately here in what we're reviewing?
They were the same at 81218.
So there were not 2 recommendations?
No.
There was a single one?
I don't know where that came from.
Correct?
Something didn't naturally sort. They were the same at 81218. Sorry about that. I just looked.
So for code 81X05, we have the crosswalk of 81218 from CAP, and we have the identical recommendation from AMP. Those are the only two that I am aware of, unless the panel sees something different. Okay, so is everybody ready to submit their ballot? If yes, go ahead. Glenn will pick it up. And while he's doing that, I'm going to turn this over to Rashida.
So for code 81X04, 1 gap fill and 8 crosswalk to 81317.
So the next code is 81X30, and this code is AS. This code is, I'm sorry, is CYP3A4. And the recommendations were to crosswalk to 81227, as well as to 81374 times 2. And I now open it up to the panel for any discussion, questions for the presenters, or recommendations. While you are considering that, I'm going to turn this over to Rashida.
For code 81X05, 9 crosswalk to 81218.
So the panel, I assume, is ready to vote. All right. Do you want to cast your ballots for 81X30? Again, we have recommendations to crosswalk it at 81277. And to crosswalk it to 81374 times 2.
Can you repeat the options? The recommendation options.
So for 81X30, that's the CYP3A4 pharmacogenetics code, we have one recommendation, actually 2 recommendations for crosswalking it to 81227. And we have 2 other recommendations to crosswalk it to 813474 times 2. Also, I'm sorry, I forgot to mention, you can always gap fill those. And please, if you are crosswalking, to kindly put the code and the multiplier or portion, as well as to sign it. So while that is occurring in terms of the collection of the ballots, we're going to move on to 81X31, and this is a CYP3A5 code. And does the panel have any questions for the presenter? Any questions to ask amongst themselves? Is the panel ready to vote? Or you need time to think about things? Let me just say that we have a recommendation to crosswalk it to 81225. There are 2 recommendations for that. And we have recommendations also, actually 4, to crosswalk to 81225. That's for 81X31. So is the panel ready to vote? Okay. no comments, so they're going to vote. Also, remember, you can gap fill. If you crosswalk, please let me know or let us know what code you're using.
Okay, voting results for 81X30. 3 for crosswalking to 81227. 6 for crosswalking to 2 times 81374.
So we're going to move on to the next code, 81X32. That's the DPYD pharmacogenomics code. And we have, let's see, we have 4 who have recommending crosswalking to 81227. Any comments, questions from the panel for the presenter? Any comments or questions for each panel member where you may need to seek more information from each other? Okay, so is the panel ready to vote? All right, so just remember we have the choices are your crosswalks to 81227, gap fill,
Voting results for 81X31. 7 for crosswalking to 81225. 2 for crosswalking to 81227.
So the next code is 81X25, and that's the F9 coagulation factor full gene sequence. And we have recommendations for crosswalk of 81321. And are there any questions from the panel for the presenters? Anybody have any questions for your panel colleagues? All right, I assume everybody's voting. And again, if you have a crosswalk, please indicate the code, and gap fill is an option. We're having a little bit of a disconnect here, so bear with us. Okay, so we have a few questions for some of the panel members, and Rashida's going to go ahead and take care of that right now. In the meanwhile, we're going to move forward with the next code, which is 81X37. and this is the G6pd code. And we have recommendations for crosswalks of 81227, 81374 times 2. And I'm opening this up to the panel. Any questions? Any questions for yourselves or the presenters? Does the committee feel that they are ready to vote on this? If yes, go ahead and complete your ballots for 81X37. Okay, so let's move on to the next code, 81X38 G6pd, gene analysis, known familial variance. So we have recommendations to crosswalk this code to 81215. And any questions from the panel? Any questions from the panel to the presenters? All right. Would the panel please cast your ballots?
Okay, results for 81X32, 8 crosswalk to 81227, 1 crosswalk to 81321. For 81X25, 6 crosswalk to 81321, 3 crosswalk to 81374 times 2.
Okay, so the next code is 81X38. It's a G6pd gene analysis, known familial variance. We have recommendations to crosswalk it to 81321. And I now open it up to the floor.
We just did known familial variant. We're on full gene sequencing.
Sorry. It's one too many codes. So, okay, so I'm sorry, I'm getting ahead of myself. So we are on code 81X40, and the panel doesn't require any discussion. That's what I'm guessing based on the looks. And you guys are ready, and you have already completed your ballots. Got it. Sorry.
So results for 81X37, crosswalk 81227, 3 individuals indicated to crosswalk to 81227, 3 voted to crosswalk 81314 times 2, and 3 voted to crosswalk to 81215. For code 81X38, all 9 indicated to crosswalk to 81215.
So the next code is 81X58. It's the hemoglobin A1, hemoglobin A2 gene analysis, known familial variant. We have a crosswalk recommendation for this code to 81241. We also have a second recommendation for 81215 times 2. Does the panel want to speak or have questions for the presenters? Any questions and discussion amongst themselves? So I would say, is the panel, ask if the panel is ready to vote. Okay, everybody's kind of nodding, so go ahead and vote.
Results for code 81X40. 3 votes to crosswalk to 81161, 6 votes to crosswalk to 81321.
So the next code is 81X59, hemoglobin, alpha hemoglobin 1, alpha hemoglobin 2, gene analysis, full gene sequence. We have recommendations for a crosswalk to 81235. And 81321. So 2 recommendations for 81X59, and those are crosswalking it to 81321. And 81235. And Dr. Schoonmaker.
Yeah, could somebody explain the difference between those? Because they're priced at roughly one's double of the other one.
So are you asking for the presenter to approach the podium and answer that question?
Which one are you, the known familial variant or the full gene sequence?
So we are on 81X59. Is that your question?
Which is full gene sequence. So what's the difference between code 81235 and 81321?
I can tell you what I wrote down. So I wrote down 81321 is P10, full gene.
So that's Dr. Sutphin speaking?
Yep, sorry. And 81235 is EGFR, and a comment that it's a similar size.
Do you need the presenters to approach the podium to answer your question?
Well, I'm just wondering what yes, I guess so, because I'm wondering what the resources are that would align with one or the other, because the prices are so different.
So could someone from either AMP or the College of American Pathologists please approach the podium? And could someone from, if you're here, from ACLA or ASCP, if we could get 2 people, one from AMP or CAP and 1 person from ACLA or ASCP to comment on this.
Nino Cerecci from AMP.
So, I'm sorry to interrupt.
Please.
Please speak a little louder and slower, because they're having problems understanding you guys.
You got it. Nino Cerecci from AMP. Our recommendation was to crosswalk to the EGFR code. As we discussed earlier, it's generally based on the size of the gene, 3 exons to 3 exons. The EGFR code contemplates sequencing of exons 19, 20, and 21, and the HBA gene is 3 exons.
So just for clarification, the EGFR code is 81235.
Correct.
This is Michael Ido, CAP. We agree with AMP's recommendation.
Thank you. Do we have anyone from ACLA or ASCP to comment on 81321? Which is ultimately what we would need to hear their opinion on the difference. Okay. In the meanwhile,
Voting results for 81X58. 8 members indicated to crosswalk to 81215 times 2. 1 indicated to crosswalk to 81235.
so Dr. Schoonmaker, you're still needing that piece of information, is that correct?
Well, it would be helpful. The 81235 is priced at $331, and the 81321 is priced at $604, so it really does make a difference. And I'm trying to figure out which one is more resource similar.
Okay, so let's do this. I'm going to allow I assume it's the ASCP representative. So ACLA is asking for more time. So let's do this. Let's move on to 8169, and we will circle back after we finish our discussion of 8169. So this is the alpha hemoglobin 1, alpha hemoglobin 2, gene analysis duplication / deletion variance. And we have recommendations to crosswalk this code to 81323 times 2. And recommendations to crosswalk this code to 81294. Do we have any questions from the panel for the presenters? Any questions for the panel, for each other, if they have questions or seeking more information? Okay, I assume the panel is ready to vote, so please submit your ballots. So, in the interest of allowing the societies to do their review, I'm going to move on to the next code, which would be 81X15, which is the human platelet antigen 1 genotyping, and it's gene analysis comment variant HPA-1A/B parenthesis L33P close parenthesis. So this is code 81X15. And we have crosswalks for this code to 81376. And does the panel need the presenters to approach them at the podium for questions? All right, no discussion amongst the panel. Please submit your ballots. Please remember you can also consider gap filling. That is also a possibility. Oh, okay. I'm sorry. Dr. Pratt?
Is there since all the HPAs are pretty much the same, can we do them in block as opposed to one at a time?
I think for our purposes today, it may be a little more efficient just to march through them. Under other circumstances, if we had done things a little differently, I would say yes. So if we know we're going to go down that road, we can just march through it if that's okay. Okay, thank you.
Results for 81X69. Crosswalk to 81323, 2 panel members. 6 recommended to crosswalk to 81294. 3 recommended to crosswalk to 81376. I'm sorry, correction. The recommendation, 1 panel member indicated to crosswalk to 2 times 81323, 6 recommended to crosswalk to 81294, and 3 recommended to crosswalk to 81376.
Okay, so let's look at 81X16 and the crosswalk for 81X16, human platelet antigen 1 genotyping, gene analysis, common variant HPA-1A/1B. Oops, sorry. It's HPA-2A/B, parenthesis T145M, close parenthesis. Our crosswalk is 81376. Any questions, comments? Do you need the presenters to answer questions? Okay, go ahead and cast your ballot.
Okay. For 81X69, the voting results are 6 for 81294 and 3 for 81376. For 81X15, 9 for 81376. Crosswalk 81376.
For the next code, 81X17, and I'm going to follow Dr. Pratt's recommendation, 81X18, 81X19, 81X20, 81X21. All of these codes have been crosswalked to 81376.
And 81X22.
Correct. So again, so for codes 81X17, 18, 19, 20, 21, 22, they have all been crosswalked to 81376. Does the panel need the presenters to answer questions? No discussion? Okay, I guess you guys are casting your ballots.
Voting results for 81X16, crosswalk to 81376. 9 panel members.
Okay, I'm gonna, while Glenn is doing that, I'm gonna circle back to 81X59. And we're going to have Mr. Shees from ACLA approach the podium. And Dr. Schoonmaker, please restate your question.
Hi.
Hello.
I was just wondering what the rationale was behind the recommendation for 81321, given that the pricing was nearly twice as much as 81235.
Right, sure. So yeah, we actually I think in all examples had tried to match up where there was a full gene sequence analysis versus common variant. We did recall from our deliberations, though, that there was an exception. We were just kind of going back through all of our comments, trying to find it. This may have been it. So we're going to go back and into our coding committee. We may follow with written comments that are more consistent with that. So
okay.
I'm not sure.
Okay.
Other than that being the original rationale.
Just wanted to give you the chance there.
Yep,
This is Dr. Vicki Pratt. I did look up HbA1 and HbA2. Both of them are 30 kb each, so the gene span 60 kb. And I don't know I didn't get a chance to look up the other, how large the other two genes were. So if AMP or CAP can look up the other two sizes for the other two genes, that would be helpful.
So regarding this code, it looks like for 81X59, we're going to circle back once we get that information. Is that what the panel is asking?
Yes.
Yes, please.
Okay, great. So we're going to move on to 81X23. That's the IDH1 common variants. So for the suggestions regarding crosswalks for 81X23, we have the code 81275. and I wanted to find out if the panel has any questions for the presenters for 81X23. Any other questions? Okay, so the panel, I assume, is ready to vote, so you can submit your ballots. Okay, so the next code is 81X24. It's the IDH2 common variance. Suggested crosswalks are 81311. Any requests from the panel for the presenters? Any discussion for 81X24? A suggested crosswalk is 81311. So go ahead and submit your ballots. And also remember that gap fill is also another possibility.
So results for codes 81X17 through 81X22 all were crosswalked to 81376, and that's all 9 panel members.
So the next code is 81X33 IDH2 common variance. Oops, sorry. It's 81X33 is IFNL, interferon lambda 3, gene analysis, RS1297980 variant. Some of the suggestions for crosswalks included the code 81241. And I'm going to open this up to the panel. Any questions for the presenters? Any questions or discussion amongst yourselves? Please submit your ballot. If you use a crosswalk, please put the code number, and gap fill is another option.
Voting results for 81X23, 9 panel members recommended to crosswalk to 81275. For 81X24, 9 panel members recommended to crosswalk to 81311.
So the folks from, I believe it was CAP and AMP, are you ready to approach the podium to provide information for the panel, or do you need some more time? Okay, I think you need some more time. All right, so let's move on to code 813XX. It's RUNX1. It's a familial platelet disorder with associated myeloid or malignancy, a gene analysis, target sequence analysis. And the crosswalks that have been suggested are 81235 times 2. And does the panel have any questions? Okay, so please submit your ballot.
Voting results for 81X33, 1 recommendation to crosswalk to 2 times 81374, 8 recommendations to crosswalk to 81241.
So for the next code, 81X34 SCLO1B1, gene analysis common variance. So we had suggestions to crosswalk 81X34 to 81376, 81381. And are there any questions for the presenters from the panel? Does the panel need to discuss this code? Okay, please submit your ballots. All right. Can we have AMP approach the podium if you are ready? And ACLA?
Thank you.
So again, please let us know who you are.
Yep. Anthony Cerecci with AMP. And after discussion with the ASCP, I think we understand what the difference in our crosswalk recommendations were. So for hemoglobin alpha 1 and alpha 2, it is two separate genes, each at 3 exons, which actually is 6 exons. So the value proposed by the ASCP, and I believe ACLA as well, for P10 is probably a little closer to the actual amount of genomic sequence analyzed for that. Additionally, there's a little additional color in that other experts have highlighted that you can use other methodologies for the sequencing of hemoglobin alpha 1 and 2, as well as EGFR. Rather than doing full exon sequencing for EGFR, you can do hotspot testing. So the value at 331 is probably more appropriate for that hotspot testing in EGFR as opposed to full gene sequencing. The P10 sequence analysis is probably a closer crosswalk. I don't know if you have anything else to say, Dr. Hilder.
You answered it.
Is that clear? Additional questions?
Dr. Schoonmaker, do you have any more questions?
So you would recommend the P10 rather than the 81235 times 2?
That's right.
If it
Or
was
we'll
six-
support the ASCP recommendation.
Okay.
I don't know that we can change ours at this point.
Yeah, we're going
Can't
with the
hear
P. We're recommending the P10. They're fairly close.
Okay.
Yeah.
So I'm sorry, who is that who is just speaking?
Oh, I'm sorry, Lee Hilborn with ASCP, and I guess I've been deputized by ACLA.
So, and the P10 code is?
81321.
Yes, the 81321. So we have consensus.
That's right.
Thank you.
Two
Anything
genes,
else?
2 genes, 3 exons. Okay, that really clears it up as far as we
Yeah.
would have we could have potentially severely under recommended
Absolutely.
for that one. So. Yeah.
All right, so we are now going to, Dr. Loy.
Can I ask Dr. Schoonmaker?
Okay, so you're going to have to speak into the mic. We can barely hear you.
Dr. Schoonmaker, I was looking at your spreadsheet and I was wondering if you could tell me, did CAP in fact make a suggestion for 81294?
So can you repeat that? Because we can barely hear you.
Did CAP make a suggestion for crosswalking to 81294?
Something happened when I sorted, so some of the cap values that look like they're really out of whack really are out of whack.
Okay, thank you.
So, yeah, sorry.
So in my summary, CAP was crosswalked to 81235.
Okay, and did they have an opinion that differed from what we heard from the consensus?
I believe they spoke, but they can come back again. Just so everybody's clear, since we're kind of toggling back and forth.
This is Michael Ido for CAP. Could you repeat your question so that I understand what you're asking?
Yeah, I'm hearing that CAP recommended crosswalk to 81235. Do you still maintain that position?
Well, since we have 6 exons, 81235 will only have 3 exons. So we will maintain 81235 times 2 or the P10. So we will actually be okay with AMP and ACLAS recommendation.
Thank you.
So, so I just want to make sure I heard that correctly. So CAP agrees with the 81321?
We do.
Okay, thank you. So what I just heard, and Dr. Pratt and Schoonmaker, is that, just correct me, what I just heard is that the dichotomy between those two codes is now no longer exists. We have a consensus that the crosswalk that is suggested is 81321. Therefore, does the committee, or excuse me, the panel have any other questions for the presenters? Any discussion amongst yourselves? So we are voting on code 81X59, and you can use the suggested gap, excuse me, the suggested crosswalk is 81321, and the suggestion for gap fill is also on the table. Please submit your ballots.
Voting results for 813XX. 1 for gap fill. 1 recommendation to crosswalk to 81235. 7 recommendations to crosswalk to 2 times 81235. Code 81X34. 2 recommendations to crosswalk to 81381. 7 recommendations to crosswalk to 81376.
Okay, so we're moving on to code 81X35, TPMT gene analysis common variance. And for 81X35, we have suggested crosswalks of 81374 times 2. And we have suggestions for 81227. Does the panel need to speak to the presenters? Okay. Does the panel have questions for themselves and want to have a discussion about these suggested crosswalks? Okay. Everybody looks pretty engaged with their ballot, so please complete your ballot for 81X35 with the suggested crosswalks of 81227 and 81374 times 2, and of course there's always the option for gap fill.
Voting results for 81X59, 1 recommendation to gap fill, 1 recommendation to crosswalk to 81235, 7 recommendations to crosswalk to 81321.
Okay, so the next code is 81X36, and it's the thymidylate synthetase gene analysis common variance. And for 81X36, we have the crosswalks of 81245. And does the panel wish to have a discussion? Do they want to speak to the presenters? Okay. Please fill out your ballots, and again, the suggested crosswalks for 81X36 is 81245, as well as the option of gap fill.
Voting results for 81X35. 5 recommendations to crosswalk 2 times 81374. 4 recommendations to crosswalk to 81227.
Okay, the next code is 813X1. It's the hemoglobin subunit beta test, common variance. Suggested crosswalks are 81227. And does the panel wish to speak to the presenters? No? Any discussion amongst yourselves? None. All right, please submit your ballots. Crosswalk suggested for 813X1 is 81227.
Voting results for 81X36. 9 recommendations to crosswalk to 81245.
All right, the next code is 813X2, hemoglobin subunit beta, known familial variance, and the suggested crosswalks are 81275, 81215 times 2. Again, does the panel need to speak to the presenters? Does the panel have discussion on these crosswalks? All right, so please submit your ballots for 813X2. Suggested crosswalks are 81215 times 2 or 81275.
Voting results for 813X1. 9 recommendations to crosswalk to 81227.
Okay. So the next code is 813X3, hemoglobin subunit beta, duplication, deletion, variance. And some of the suggested crosswalks are 81275, 81215 times 2. Oh, excuse me, that is incorrect. The suggested crosswalks are 81294. And does the panel want to speak with the presenters? Any discussion amongst yourselves? All right, so for 813X3, the suggested crosswalk is 81294. Crosswalks that you may otherwise entertain are also acceptable, and of course there's always gap fill. Thank you.
Voting results for 813X2. 8 recommendations to crosswalk to 2 times 81215. 1 recommendation to crosswalk to 81275.
So the next code is 813X4. It's the hemoglobin subunit beta full gene sequence. And for 813X4, we have suggested crosswalk or crosswalks of 81235 and any other crosswalks that you may want to entertain as the panel. Any discussion? Any questions? Okay. Please submit your ballots for 813X4. The crosswalk suggestions of 81235, those in which you would like to entertain, and of course gap fill.
Voting results for 813X3. 9 recommendations to crosswalk to 81294.
So the next code is from the genomic sequencing portion of the AMA CPT manual. The code is 814X5, Hereditary Peripheral Neuropathies panel. It is a genomic sequence analysis panel, and it has to include at least 5 peripheral neuropathy-related genes. And some of the recommendations that we have had to date are for Crosswalk 81439. Does the panel have any questions for the presenter? Dr. Kuchar-Lapati.
Let me ask a question about these two tests. And one of these tests, it seems like, has only 5 genes.
So
the other test has 100 genes.
Can you speak right into the mic, please?
Yes, I'm saying that it looks like that the tests are somewhat different. Although they're all looking for peripheral neuropathy, one of the tests has less than 10 genes, the other one has 100 genes. And having both of them in the same code doesn't seem to be appropriate.
So does the panel want to comment on that? Dr. Kuchar-Lapati, is your question meant for the presenters?
I think it's for all of us, whether those two are indeed equivalent to each other.
So let's start with the following. So are there physicians from Mayo Clinic here? Great. Can someone approach the podium?
Hi, I'm Neil New. I'm a lab director at Mayo Clinic. So I think right now for lots of GSP code, including the cardiomyopathy panel, are becoming kind of like the descriptor become including several genes, but not really require a fixed 5 gene or 10 gene. And we keep adding more genes onto the panel, and that's happening in lots of panel, not just for the neuropathy panels. And in the practice, we see the value of comprehensive evaluation. The peripheral neuropathy panels are covering a few large categories, including like sensory, axonal, autonomic, and they share a very similar phenotype, and sometimes it's very hard to distinguish between each other, and that's maybe something a little bit different compared to cardiomyopathy panel. You are mainly looking for dilated cardiomyopathy or for glucose genes, or hypertrophic cardiomyopathy for glucose genes. So unfortunately, like we have a very, very big large number of genes on our panel right now.
Dr. Kuchar-Lapati, does that answer your question?
I understood what he said.
I'm sorry?
I understood what was said.
Okay. Can I clarify one thing? So, let me just say that the code 81439 by some, the recommendation was with the multiple of 1. And another suggestion was 81439 times 3. So I apologize. I needed to make that clarification. Having said that, are there any other questions for the presenters? Any other questions within the panel? Any discussion? Okay, so please submit your ballots for 814X5. Some of the suggestions for crosswalk are 81439 times 1, 81439 times 3, gap fill, and other crosswalks as you see fit.
Voting results for 813X4, 1 recommendation to gap fill, 8 recommendations to crosswalk to 81235.
So the next code is from the MA section of the CPT manual. It is code 815XX, oncology, breast, mRNA gene expression, profiling by hybrid, capture of 58 genes utilizing formalin-fixed paraffin embedded tissue algorithm reported as recurrence of risk score. For code 815XX, we have had suggestions to crosswalk to 0008M. And are there any questions from the panel for the presenters? Dr. Kucher-Lapati?
So what is the difference between 0008M and 87501? They're the same amount.
So can we, is there, okay, so I'm assuming this is a question for anybody, correct?
Yes.
All right. So Dr. Pratt, can I ask you a quick question?
Sure.
Can you answer his question? Because I am not
I would need the
pathology
question
specialist.
repeated because I was, Michelle Shoemaker and I were discussing the code.
That's okay. Go ahead, Dr. Kucher-Lapati.
I'm just asking what the difference between code 0008M and 87501.
So the ProSigna assay had only an Appendix O tracking code. Now that they are FDA cleared, they requested that, so they have requested a Category 1 Category 1 MAAA. So the 8008M is the ProSigna assay prior to being FDA cleared. So it's the exact same assay and the exact same amount of work and resources.
May I add also, this is Vicki Basowski, 87501, I think we've got a typo in the spreadsheet. That's actually an infectious disease agent molecular test. So I think that we have something off the line in the spreadsheet. So the recommendation was a 0008M, and the other one is we've got something wrong with the spreadsheet. That's right.
Okay.
So what I have in my notes and review of the presentations, I have only identified one recommendation for 815XX, which is 0008M. Having said that, are there any other questions from the panel? Does the panel need to get clarification from the presenters? Okay, so no one would, okay, you guys are pretty clear on that. The crosswalk that was suggested is 0008M for 815XX. So go ahead and vote.
Voting results for 814X5. 4 recommendations to gap fill and 4 recommendations to crosswalk to 81439.
All right, the next code is 815X1, oncology, prostate, promoter methylation, profiling by real-time PCR, 3 genes, Oops.
Huh?
Sorry. I'm sorry. That's my error. So scratch what I said about X1. We're going to do 815X2. I apologize. So this is the oncology breast, messenger RNA, microarray gene expression profiling of 70 content genes, 465 housekeeping genes utilizing fresh frozen or formalin fixed paraffin embedded tissue. The algorithm is reported as index related to risk of distant metastasis. So for 815X2, We have suggested crosswalk of 81519. And do we have any other discussions, questions, etc. from the panel? Okay, everybody looks pretty content. So for 815X2, the suggested crosswalk is 81519. So that is an option using your own crosswalk or gap fill.
Voting results for 815XX, 1 recommendation to gap fill, 6 recommendations to crosswalk to 0008M, 1 recommendation to crosswalk to 87501.
Okay, so the next code is 81X41, oncology, prostate, messenger RNA, gene expression profiling by real-time RT-PCR, 46 genes, 31 content, 15 housekeeping, utilizing formalin-fixed paraffin embedded tissue, algorithm reported as a disease-specific mortality risk score. For code 81X41, the crosswalks that have been suggested are 81519. And so my question for the panel is, do you need to hear from, or would you like to ask questions of the presenters? Discussion amongst yourselves? And I assume you are ready to vote. So your ballot would be for 81X41 with a suggested crosswalk of 81519, or gap fill, or a crosswalk of your suggestion.
Voting results for 815X2, 2 recommendations to gap fill, 6 recommendations to crosswalk to 81519.
So for 815X1, this is the oncology, prostate, promoter methylation profiling by real-time PCR of 3 genes, utilizing formalin-fixed paraffin-embedded tissue, algorithm reported as a likelihood of prostate cancer detection on repeat biopsy. Dr. Schoonmaker, can you let me know what are the crosswalks that you have for this code?
I didn't have any.
Okay.
Their recommendation was to gap fill.
Okay, thank you.
That's why.
Does the panel have any questions? Do they need to ask the presenters anything? Okay, so for 815X1, no suggestions for crosswalk. You certainly can add that if you would like. Their suggestions were for gap fill.
Results for 81X41, 5 recommendations to gap fill, 4 recommendations to crosswalk to 81519.
Okay, so now we are moving on to the immunology section of the CPT manual, and the first code is 8600X, and there were suggestions to crosswalk to 86157 and 86003.
Only thing that was recommended was gap fill.
And do we have any questions from the panel? So for
This is Vicki Bosowski. I would like to ask the presenter to provide some clarification. It appears to me that the component resolved diagnostics are being described as having increased costs associated with them, and that's the justification for the increased pricing recommendation over 86003. So if we could have a little more discussion of why the component resolved diagnostics should be priced higher.
Yeah, so during the presentation, I believe, and then in some of the follow-up, I discussed how probably the most appropriate code for crosswalking to is 86003 because the similarity in methodologies, these tests, both the whole allergen test, 86003, and 8600X-CRD tests are both run on the same instrument platforms. The difference is in the actual development and manufacturing of the kit costs. And the reason, to kind of go back to the differences in them, so with whole allergen crude extracts, those are relatively inexpensive analytes to manufacture. There's no R&D process involved. You literally identify an allergen source, whether it be a food like peanut, you extract. You just extract the proteins and you're bonding that to a solid phase. Or you shave a cat and you make an extract from cat hair and or cat pelts, and again, so it's a very relatively crude process. Very relatively quickly done. Manufacturing any given lot of these whole allergen reagents takes about a month. Comparatively with component tests, manufacturing for any given lot of component takes about 10 months. So a much longer manufacturing process. And then to go back one step, the actual preclinical identification and validation process. So when we go to any given allergen source, we have to characterize all the individual whether they be proteins or carbohydrate molecules that may have allergenic properties. We have to assess their clinical validity. And so that process can take, on average about 2 years for any given component. So compared to whole allergen extracts where there's absolutely no preclinical work or R&D involved, it's just give you an allergen source, extract it, put it onto a solid phase, versus a component test where you're doing preclinical work, seeing which proteins are actually, or molecules are actually relevant to developing tests, which have clinical applicability. That can take, like I said, 2 years, 10 months of actual production. And then there's also the IP and licensing fees for a lot of these components, which can actually add up to 4 times the cost, 4 times of the production costs. So that's the disparity in the cost of the kits. Once again, the whole allergen extracts, relatively inexpensive to make, very relatively more simple procedure. The component tests, much more complicated, much more longer drawn out. We manufacture them through recombinant DNA expression. So that's the difference for the kit price.
Okay, so let me just say we have 6 minutes, and and I think what happens is we get cut off. So what I would like to do is, this is the last code of the day, and we have 1, 2, 3 panel members who have questions. So if you could keep your questions specific and the answers specific, that would be great. So I think it was Dr. Kuchar-Lapati, then Dr. Schoonmaker, and then Ms. Davis. So in that order, please ask your questions.
the fact that you have your assay can specifically detect the antigen, does it have clinical significance?
Yes, it does. You can actually, and just a very classic example we'll give is with peanut allergy. Peanut allergy doesn't always mean you have anaphylaxis with peanut. Some patients have just oral allergy, oral itching, and it doesn't actually escalate to a systemic reaction. And this is where the components can be really helpful. With these different markers, we can actually differentiate patients that are more likely to have a systemic reaction versus patients that have more local reactions.
All right, Dr. Schoonmaker.
That was basically my question too. The code 86003 is specified for each allergen, and how many different components do you test for, and do they have clinical significance?
Yeah, so I think the clinical significance we just went to, so I won't expound upon that further. But in terms of the number of, it's going to depend on the allergen source. So for example, peanut, there are currently 5 allergen components that are available for that, and soon to be 6, and that's probably where it's going to stop. There probably won't be any more for peanut. For other allergen sources, there may only be 2 or 3. It just depends on the allergen source. But right now, peanut is probably the one that has the most components assigned to it.
Thank you.
All right, Ms. Davis.
Was there a quantitative reason that you came up with a unit of 5? Or is that just to express that it was more expensive?
Yeah, no, it wasn't purely, it wasn't arbitrary, if that's kind of what you're getting. It was not arbitrary. So it was a combination of factors between, when we look at our development and manufacturing costs relative to whole allergen components, and then also, in combination with, and that sort of factors into the list pricing as well. So that's how we came up with that.
Dr. Morrison?
Carl Morrison, if I remember correctly earlier, you said that the kits cost laboratories from $18 to $45?
18 to 50 is the range. The weighted average is $46.25.
And you also said that you felt that the laboratory effort was equivalent to 1 unit, correct? One of your X units of 8,600?
86003? Is that, or? I'm confused.
Yes.
Yeah, yes.
So then why don't you price the test at either the 50 plus 1 unit or the 18 plus 1 unit? It's either the maximum or the minimum. Which one should it be?
I'm not sure I'm following. 50 plus 1 unit or?
I thought you reached that times 5. My question is kind of similar to hers, that you took the medium cost that labs pay for the kit,
sure,
plus the labor unit, and added to that and said it was equivalent to that code times 5, correct?
Correct.
But of that times 5, 4 of that was related to the price of the kit, and 1 unit was related to the labor in the laboratory, correct?
Correct. Yep.
So I suppose my question is, are you trying to hit the middle lab? Are you trying to hit the most efficient way to do this, or the most inefficient way to do this?
I don't know how to answer that other than, yeah.
Are there any other questions from the panel? Do you require further discussion amongst yourselves? Are you ready to cast your, okay, Dr. Hamilton.
If we're ready to vote, I recuse myself because of a research alliance with the company.
Okay, thank you. Please indicate that on your ballot. All right, any other true confessions? All righty. So let me just say, please cast your votes. Thank you, Dr. Yang. Also, this is for the public while the panel is casting their vote. So we have moved along this afternoon with the panel assessment of the codes. So tomorrow when we start, we're going to pick up where we left off. So therefore, all of the presentations that were anticipated for tomorrow will be moved up earlier. So I just want to share that with you. Okay, so we'll let you know about this outcome in a second.
For 815X1, 8 panel members recommended to gap fill, 1 recommendation to crosswalk to 81241.
And this is for the panel members. So tomorrow, as we discussed, we will start again with the administrative meeting at 8 a.m. and we will meet you at the front desk and take you to the appropriate conference room. So we have just a little bit of an administrative question for the panel. So let's, once we get this straightened out, we can announce the outcome. Also for the panel, just one little last housekeeping item. So please take all of your items, including your name placards, with you, and then bring them back tomorrow. Thank you.
Okay, for code 8600X, 5 recommendations to gap fill, 1 recommendation to crosswalk to 86003 times 5, 1 recommendation to crosswalk to 86003 times 4, and then 1 recommendation to crosswalk to 86157.
All right. Thank you very much. We will reconvene tomorrow at 9, and we will start on the next code.
Unfortunately,